Hello and welcome to a Health Podyssey. Today we are bringing you a special live episode. In today's episode, David Blumenthal, president of the Commonwealth Fund, interviews Micky Tripathi, the current national coordinator for Health IT. The conversation took place on July 1st, 2021, and was part of a policy spotlight series from Health Affairs. This is a live event, so the audio is a little different from regular Health Podyssey episodes, but the content is no less insightful. Thanks for listening, and sign up for our daily newsletter to stay up to date with Health Affairs events.
I'm David Blumenthal. I'm currently the president of the Commonwealth Fund, which is a national philanthropy devoted to improving the performance of the healthcare system. I am also a former national coordinator for health information technology from 2009 to 2011. So it's a very special privilege and pleasure for me to have the opportunity to talk with our current national coordinator. I also owe Micky a debt of gratitude because he was an important advisor to our work early on in the HITECH Act, serving on some of our advisory committees and helping us formulate some of our original meaningful use and standards regulations back in the day. Micky, aside before his current role, was a pioneer in the world of health IT interoperability, running the Mass eHealth Collaborative. He's also had multiple other senior roles in the IT space, a number of them devoted to interoperability and its promotion. He was the project manager of the Argonaut project, and he's been a board member of HL7, the Sequoia Project, the Commonwealth Health Alliance, and the Karen Alliance. So very few people more qualified to hold the role he has than he is right now, and very much look forward to a conversation with him. So let me start, Micky, by asking a general question, and that is, from your standpoint, what are the priorities for the administration with respect to health information technology?
Yeah, great. First off, thank you, David, and thank you to the Commonwealth Fund and to Health Affairs for the opportunity to be here today. And always a delight to be with you. And and any of the hard questions, I'm going to pitch back to you since you're qualified to answer them as well. A few things that I would highlight in terms of ONC priorities. Obviously, first and foremost, helping to do everything we can with respect to the COVID response, which things have been looking relatively good in this country and turning the corner, but we know we're not completely around the corner, and there's still a lot of work to do for us to get back to where we want to be. And so everything that we can do, and that's related to very specific things, related to helping to try to help with scheduling, trying to help with vaccine information availability, and doing a lot of work with the CDC, particularly with regards to an executive order related to evaluating the public health data system response to COVID, and what lessons can we learn from that experience that can help inform how we can have a better data-driven response to high consequence public health like COVID going forward. So that's top of mind for ONC as well as all agencies. We also have a bunch of other things that we need to keep doing as well. And so, a couple of those that I would flag are one, certainly the implementation of the 21st Century Cures Act, which was passed and signed by President Obama, and Vice President Biden in 2016, and has some, very fundamental components to it that are, just vital aspects of how we're going to think about interoperability in the future. The two that I would call out are, one, the information blocking parts of that rule, which are about information sharing. It's really something that should be called information sharing, not information blocking, which requires organizations to make information available to patients as well as other providers through APIs that are accessible without special effort. Was a particular reason. I'm happy to dive into the details of that as we continue. The second is related to nationwide interoperability. It's called TEFCA, the Trusted Exchange Framework, which is about creating a governance model to have more seamless integration of the various health IT networks that are out there in the market today.
So you've opened up two issues that I do want to drill down on. One is the public health data infrastructure, which we are all acutely aware of as to its failings in the pandemic. And I don't think that's criticism of any particular group or agencies, but it just reflects years and years and years of underinvestment in our nation's public health infrastructure. And the second has to do with the implementation of the Cures Act. So let's talk about the public health infrastructure priority to start with. Now, I know that you are formulating policy with respect to that, so all the answers may not be in. But if you had to guess where policy would take us with respect to developing the decentralized, diffuse public health information architecture that we need in order to manage pandemics in the future, where would you expect ONC and the administration to lead us, along with CDC, of course?
Yeah, and obviously, as you've pointed out, I'm not going to speak for the CDC on this, but certainly I'm aware and working very closely with them on the investments and helping to advise them along the health IT, parts of the investments that are being made to, that's all under the sort of the umbrella of the data modernization initiative that's going on at the CDC right now. So, I think that one of the sort of the aspects of the COVID response now that we have is that there are now resources available to be able to make some investments. But one of the challenges that we have is that is how best to make use of those resources. And unfortunately, in some ways, it fits within the historic pattern of feast or famine that that as a country we've had with public health. After crises, we tend to inject a whole bunch of money, and then that money starts to fall away, and then there's a long periods of time in between crises where we sort of underinvest in the public health systems, and that presents a challenge for making sort of a rational, sustained investment to create the kind of public health information system that that everyone living in the United States deserves. So I certainly the things that we are working on with respect to the CDC's program, and we're working very closely with them on some priority areas. And so I think that at sort of a broad level, I think what the CDC is trying to accomplish is to say, how do we create a general ecosystem where we think about an ecosystem of data sharing that doesn't have sort of the stovepiping that we have today. So right now we have the clinical systems which live in one world, we have administrative systems that live in one world, and then we have public health systems which live in a different world, and they don't intersect very often. And I think that that as we think about the future, what we want to be able to have is an integrated ecosystem where you're able to have information exchange according to purpose, but not stovepiped in these separate, often redundant ways of sharing information. So I think that's a general goal, and there are multiple different ways to accomplish it. Some of the specific areas that ONC is working on, where we have sort of capabilities and levers that we can help to pull in the direction of supporting that that vision, are how do we integrate public health and clinical system interoperability and general interoperability, and how do we enable cross-jurisdiction sharing? Because one of the things that we saw as a part of the pandemic, and we've heard loud and clear from the various jurisdictions, meaning states and local public health entities, is that they had challenges sharing information upward, sort of a hub and spoke with the CDC, and no ability to share information with each other. And you can imagine the challenge of that when you are, adjacent states, for example, and not being able to share information with each other in an easy manner. So the areas where ONC can help with that are related to TEFCA, the Trusted Exchange Framework, and we'll have more to share this summer about that. But that is the nation, that is called out in 21st Century Cures to provide a nationwide governance framework for nationwide interoperability. And one of the goals that we have of that is to not only have providers be able to exchange information with each other, but to have public health be a direct participant in that kind of network, so that we don't have the challenges that we have today of these kind of silos or independent pipes for public health, but they're a part of a general information sharing infrastructure that's that's already up and running, but that doesn't yet allow public health to participate. So that's one of the things that I think we can focus on. Another is, how do we get better data standardization? One of the things that we saw in the pandemic is that, for example, we don't have good lab standardization across the country. So you have public health systems that that were getting lab information, and one of the sort of the anecdotes that we know of is that the CDC, for example, had identified 2 very specific lab codes that labs were supposed to use for COVID tests. And what got reported by a number of organizations was that public health systems were receiving 200 different types of lab codes representing COVID, because there was no monitoring, there was no enforcement, there was no requirement that people just limit themselves to these 2 codes. And as you can imagine, that presents huge challenges if you're getting those kinds of variations at every public health system trying to deal with that. The other challenge that we saw, which is again a nitty-gritty on the ground issue, is patient matching. So you'd have public health systems that are receiving case reports from physician practices or hospitals, and then they're getting a separate feed of electronic lab results, but there's not enough demographic information, and of course we don't have a nationwide patient identifier. There wasn't enough information for them to do with certainty the matching of that data. So you have these separate streams of information. You know that some of them are on the same patient. That would give you a better perspective on what it is you want to do, but no ability to match that data. So those are the kinds of things that we saw, and better data standardization will help with that. So ONC is directly participating in helping to lead the SHIELD project, which is a project to enhance lab interoperability. And we also have something called the US CDI, which is the US Core Data for Interoperability, which is a set of standards that ONC promulgates that are requirements that EHR systems make available in their systems in a standardized way. So we're working very closely with the CDC to see how can we have an extension of the US CDI that might directly apply to public health, to be able to have greater standardization of public health data. A couple of other things I'll just mention very quickly. How do we introduce FHIR-based exchange patterns for interactivity with healthcare systems? One of the challenges that we have with current public health systems is that they're essentially a one-way flow. It's information that flows from a provider system, let's say, to a public health system without any information coming back. So if we want to turn this into actionable kinds of things, FHIR, which is an emerging, an emerging standard in healthcare, which is an API-based, sort of approach, allows that kind of interactivity. So you're able to take that information, and then public health systems can push back information, actionable information, based on analysis, based on other things that they've done with the data, to be able to inform people about, how best to do that. So there's a variety of things that we're pushing hard on with the CDC to exercise all the levers that we have to help support the CDC and its vision.
I'm going to move on past public health. And one of the many things that occurs to me is, how do you get all the providers who are doing these tests for the various pandemic-related phenomena to adopt the same standards as the public health infrastructure is going to? And maybe that works from that common set of standards that you just discussed as having promulgated as part of ONC's mandate. But let me move on to talk about interoperability within the healthcare delivery sector. It seems to me like there are 2 prevailing theories for getting interoperability. One is a bottom-up theory, and the other is a kind of top-down theory. The bottom-up one is, let's make sure that patients can get their data out of either insurance companies or electronic health records, and we'll find third-party agents who will collect that data and collate it and provide it to individuals in a form that they find useful. And the other is the traditional health information exchange prototype that dominated thinking when I was national coordinator, which is business to business, provider to provider exchange. How do you see those 2 working together or coming together, Micky? And in the case of the provider to provider exchange, how do you think things are going with respect to information sharing in the aftermath of the Cures Act and the recent promulgation of the implementing regulations?
Yeah, I mean, it's a great question, and I think you've sort of captured the different sort of high level concepts nicely. So there is I think that there are these two kinds of approaches one might think of. To me, they're not it's not an or, it's an and. That you've got to have the B2B essentially network, which is provider to payer, kind of that back end interoperability. That's got to be there as something that that providers and other healthcare institutions can rely on, because we need to make sure that they are able to get the information that they need without having any sort of gaps in their ability to be able to get that information. And I think that we want to be able to enable patients to have access to their information and be the conduits of that information if they choose to be. And I think one of the challenges is that we don't know whether patients will choose to be those kinds of conduits. There are many patients who may be interested in that, and so we want to do everything that we can to make that information available to them without special effort, as the 21st Century Cures Act says, as just sort of an ethical and moral as well as legal obligation now to make that information available to them so that they can make the choices that they want to make about the control, about what they do with that information, who they provide that information, sort of access to, and what other kinds of services that they want to be able to, have, provide availability of that information to, that might live outside of the traditional healthcare settings, like their hospital or physician offices. But the reason I say that it's an and is that I don't think that we don't yet know whether all patients want to do that. I mean, I think that that for a lot of patients, me for example, I really don't have a whole lot of interest in being at the center of that because I'm afraid that I'll drop the ball. And I'd much prefer having the assurance that my providers are exchanging that information, have it available, and that I have access to it should I want it. But I don't want to be the one who's that everyone is relying on. But again, we want to make sure that that all of those paths are available paths for for the multiple ways that information can flow to be able to serve all the different use cases that are out there.
And how are we doing with respect to information blocking? Have you seen, and I realize that there may not be systematic data about this, but how do you, what are you picking up? What do your antenna tell you about the ways in which providers are relating to one another? And we all know that the lack of a business case at the ground level for information exchange has always been the most important impediment to information exchange between providers. And so now we have, instead of a business case, a positive business case, we have a stick that is wielded over providers should they fail to comply. And how do you see things going?
Yeah, I mean, I think that I think that things are going very well. In the sense that we're starting to get a lot of industry engagement, a lot of provider engagement, technology developer engagement, in understanding and wanting to learn more and understand, exactly what information blocking means, how they can, bring themselves, into compliance with the requirements. And what what we're trying to do from an ONC perspective is get as much education and outreach available so that organizations understand the compliance aspect of it, but more important, understand the opportunity aspect of it. So, from a compliance perspective, we are fielding questions, every day from organizations, and we embrace, getting more and more of those questions because I think, as you know, David, from your time at ONC, it's not a bug of the system; it's a feature of the system that you promulgate a complicated rule. And then you keep trying to clarify, trying to understand people's questions, and keep trying to provide more information to the market about, about what the rule means, what the rule says about particular circumstances, because healthcare is unbelievably heterogeneous in this country and very fragmented. And so there's no, sort of codified rule that is going to cover every circumstance that, that exists in every corner of the healthcare delivery system. And so that's very much a part of it. And so I think we're starting to see more and more questions come now that the applicability date has come and gone, on April 5th, and now now, it is a requirement to be in compliance with it. So from that perspective, I think that, that things are going well. That doesn't mean that there aren't concerns. And we certainly have, are hearing a lot of concerns. We're speaking with as many organizations as we possibly can. Seeing, doing that in large settings as well as, more focused settings to understand the concerns that they have and to try to answer as many questions as we can. I mean, I am, really gratified to see a lot of organizations, including my own provider, it was a surprise to me. I mean, I didn't, plant the seed with them, but I logged into the patient portal, last week or the week before to schedule an appointment for my own care. And what I was met with was a banner that popped up that said, "We are now embracing patient engagement in an exciting new way. We're going to make results available to you as soon as they are available to us," and then provided some direction about, if you want to be able to talk to your provider before seeing those results, please wait before looking at them and your provider will contact you. Otherwise, if you want to look at them right away, they're available to you. So I think we're starting to see the technology developers as well as the providers starting to embrace what, the nitty gritty and what the details are of information blocking. And more important than the nitty gritty, they're starting to embrace the spirit of it and starting to think about the solutions for moving forward.
So I have a nitty gritty question that just occurred to me, and that is, who is responsible for enforcing the regulation?
Oh my God. How much time do we have? No, so it is very complicated. So let me just try to, put it in simple terms, not because the audience is simple, but because it would take a lot of time or too much time that we have, or probably want to spend on this particular one. But the law specifies somewhat of a, a shared responsibility with respect to enforcement. So what the law specifies is that ONC sets the policy on what is information blocking, what are allowable exceptions, which ONC did by rule, which went into effect on April 5th. And then it specifies that OIG, the Office of the Inspector General in the Department of Health and Human Services, is responsible for enforcement of the rule, which is to say that it also specified that ONC will receive complaints from the public, from actors who believe that there is a violation of information blocking that they have encountered, that we will receive complaints, that we will pass those to OIG. OIG will determine enforcement, and then this is where it gets even a little bit more complicated. What the law specifies is that for 2 of the 3 types of actors that fall under information blocking, which is to say technology developers and health information networks, the law says that they will be subject to civil monetary penalties of up to $1 million per incident. And it says that OIG will determine whether a violation has occurred and will determine the civil monetary penalties for those. But there's another very important actor in addition to the technology developers and health information networks, which is providers. And what the law says is that the secretary will determine what are called appropriate disincentives for providers who are found to be in violation of the information blocking. And so OIG will determine whether a provider is in violation if a complaint, if a complaint has come in. But then there is a process that the secretary still needs to define with respect to what are the penalties. And that's a process that that we have sort of kicked off within the Department of Health and Human Services to figure out exactly, how are we going to determine, what are those appropriate disincentives and how will they work. So there's more to come on that, but we are actively working on that to fill in that last piece of the puzzle, which I know is a great source of interest and and a little bit of anxiety for providers because they want to know what could be the penalties if they are found to be in violation of the information blocking rule. So more to come on that. It's very actively being looked at. The last point I will make is that the law did specifically say that that the secretary will determine those appropriate disincentives, and so in theory that could be applied to any funding or program that comes from the Department of Health and Human Services. So that doesn't mean that it's not limited to a CMS payment or MIPS incentive payment, for example. It could be related to any other program that an organization participates in that comes under the umbrella of the Department of Health and Human Services, which could be NIH, HRSA, ARC, IHS. I mean, there's a wide variety of programs in Department of Health and Human Services that, in theory, could fall under the umbrella of appropriate incentives. But that's being worked on right now. I told you it was complicated.
Yeah, it's worthy of our federal government in its complexity. We have a couple of questions from the audience. One of them concerns the Biden administration priority around equity and how the data modernization program, I guess at the public health level, but also presumably in the delivery system area, how it will accommodate the fact that there are some institutions and parts of the country that are much better resourced than others. And the less well-resourced ones tend to be those that have larger numbers of marginalized individuals within their catchment areas or within their geographic purview. So how is that equity thrust, which is so prominent in this administration, figuring into your thinking about the health IT agenda?
Yeah, I think there are a couple of things to say on that. One is there are certainly more resources being made available to those organizations that work directly in communities that have been underserved and under-resourced in the past. So if you look at the grants coming out of SAMHSA, the grants coming out of HRSA for health centers, there's more and more money being made available to those organizations that are serving on those front lines. The second thing I would say to it, though, which I think is a really important aspect of this, is that from an ONC perspective, what we're doing is focusing on what we're calling health equity by design, which is to say, how do we step back and ask ourselves, what's the role that health IT can play with respect to identifying health inequities where they exist as far upstream as possible, to be able to identify and perhaps intervene to prevent the healthcare disparities that result from those health inequities. And so in particular, it begins with data. And this, applies to any organization, any hospital, whether it's a safety net hospital or, a well-resourced hospital, in a more affluent part of the country, that you have that core capability, which is required in a certified EHR system. And so what we're doing with the US CDI, for example, is working really hard to ask ourselves what kind of data needs to be made available, needs to be made available for capture in those systems, because all of this starts with data. And to quote a health equity expert who we had the privilege of talking to last week, if you're not counted, you don't count. And so we need to be able to start with saying, how do we have that granular information captured, to begin with? So we'll have, more information that we're able to share on that with the coming US CDI release, which is going to be released in the next few weeks here. But it starts with that. But as we think about the entire value chain, it doesn't end with that. Because that data has to be appropriately curated. You've got all sorts of issues about the way data is analyzed. We know more and more stories about algorithmic bias, for example, and all sorts of other implicit and in some cases explicit bias that resides in the way that we calculate quality measures, the way we calculate other kinds of things in the analytics. And then what are the applications and how is that surfaced in systems that people use that can then be turned into actionable workflows? And I think you start to think about that as an end-to-end problem. And now we're doing a lot of work to say, from an ONC perspective, how do we map the things that we do with respect to health IT into areas that could be areas of focus? So one is data, as I just described. So we're spending a lot of time thinking about how do we get that from the beginning, is to say we have more of that data available in ways that are interoperable, shareable, and actionable, so that downstream people can make better decisions. And then how do we think about intervention more upstream? So a particular example of that, for example, is, we think a lot in the industry about SDOH, of social determinants of health data, and making social determinants of health data more available in acute care settings, let's say, so that decision-making can be more holistic. But that's and if you think about the way that works, that's only solving a part of the problem, because you're saying, I want to get more data from upstream to be able to make interventions downstream. But what I really would like to do is make more interventions upstream to prevent the problem, where it lives. And so, you start to think about, well, why don't we have more interoperability with social service organizations, for example? To your point, before, we spent a lot of time on interoperability, provider to provider, hospital to practice, hospital to hospital. How about hospital to social service agency, so that I can order legal assistance seamlessly in my system, so I can order housing assistance seamlessly from my system in the same way that I would order a lab. We're starting to give a lot of thought to that, and we actually have an innovation award that we'll be announcing later this month for an organization that's going to be working specifically on developing those kinds of capabilities with social service organizations that we hope will provide some scalable results and lessons for the rest of the industry.
Terrific. Do our certification requirements now require the capability to collect race and ethnicity data?
Yeah, no, they do. There is, one of the things, and this is an area that we're looking at now in the federal government as well, is how do we capture race ethnicity data in a consistent way, across the government. Anyone who's sort of is familiar with this area knows that there are the requirements for the OMB 5, the 5 categories that OMB requires with respect to race and ethnicity, and everything has to roll up to that. But then there are a variety of other data sets that are used in various places. There's the 2011 HHS survey, data sets as they're called, and then there's the CDC data set, which is over 900 race ethnicity categories. From an ONC perspective, EHR certification requires that EHRs support the CDC data set, which is to say the most granular of the data sets that I just mentioned, which is those 900 categories. The systems are required to support the CDC data set, and they're required to support the roll-up into those 5 OMB data sets. So that's what the systems are required to support. The challenge is that providers aren't necessarily required to record the information at that level of granularity, and that's where you have the rub in terms of the variation that we see out in the market. Some provider organizations are very diligent about it and do spend a lot of time in their workflows and their front end processes and their registration processes to try to reach out as much as possible to record that information in as detailed a manner as the system allows. Others just don't do that, and they record it at the highest level of granularity. So I think a lot of the work that we have to do now is to understand how we can have better processes to be able to capture that data. That's that's both respectful of the difficulty from a workflow and front end perspective, but is also sensitive to the fact that individuals may not want to share that information for a variety of reasons. And how do we overcome some of those barriers to help them understand that information will be put to good use and used securely in a way that will benefit them from a care perspective. Just before this meeting, I got off an amazing presentation from UCLA about the work that they are doing to do just what I described, which is to say, reaching out to patients separately to describe why are we asking these detailed questions about your race, your ethnicity, your sexual identity. Here are the reasons that we're asking those to improve your health, and here's how that data is being protected. And I think we need to do a lot more work in thinking about that part of the problem.
Does the 21st Century Cures Act require the same level of compliance with regard to interoperability and the capability thereof as it does of providers? That is, are there penalties for developers, the Cerners and the other vendors of the world, in terms of making sure that they are fully capable of interoperability?
Yep.
Or is that just a certification issue?
Yep. No, it's not a certification issue. They are an actor under information blocking. So the 21st Century Cures Act specified 3 actors that would be subject to the information blocking provisions. One is providers, one is technology developers, which would include EHR vendors, for example, and then the third is health information networks or health information exchanges. They will all fall under that umbrella. So each of those are actors that are subject to the information blocking provisions and the same provisions. So it's the same exceptions would apply, the same rules about what constitutes information blocking and what constitutes interference apply to all of them. With the technology vendors and developers in particular, that's, as I was describing before, the law actually specifies a significant penalty, which is a civil monetary penalty of up to $1 million per incident. And so you can imagine a circumstance where, depending on how OIG might define incident, let's say, in a particular case, that could run up into the millions of dollars if one is found to be knowingly in violation of or interfering with the sharing of information if you're a technology developer. So yeah, there's very much are rules and penalties associated with it, and technology developers I think are very aware that there's hard cash monetary penalties there for for them if they're found to be in violation.
Great. Let's focus a little more now on the uses of information and less on the infrastructure for making information available. And this, of course, moves us into the area of artificial intelligence. One of the things that we always, early in the history of high tech, were hopeful of is that sophisticated decision support would spread rapidly once data was stored in electronic form. We are now talking much more about the technical work, the algorithms that produce decision support. A lot of that is now called AI and machine learning. How do you see that ecosystem evolving now? Has the availability of FHIR and APIs created the opportunities that we all were hoping for with respect to artificial intelligence and the decision support that would flow from it? Or are the incentives for that still nascent?
Yeah, no, so I think there's tremendous progress with respect to AI and the availability of data for AI, which we can talk about in a second. FHIR hasn't been a significant contributor to that specifically, and the reason for that is that right now we're really at the beginning of FHIR adoption. Interestingly, even though we've got rapid adoption of FHIR-based capabilities across the ecosystem, according to ONC surveys, well over 80% of providers, that's hospital and ambulatory providers, have EHR systems in place today that have some type of FHIR-based capability in them. And that's despite the fact that right now there is no regulation that requires any of those systems to have FHIR-based capabilities. The regulations that are in force right now say that they have to have an API. It's a functional specification that says that they have to have an API, a patient-facing API that has certain functions and provides certain types of structured data. It doesn't specify FHIR. Despite that, because of the Argonaut project and a number of other FHIR accelerator activities, vendors have embraced FHIR and have implemented FHIR as the way to do that, but we still see variation across those systems. The Ehr Certification Rule that accompanies the information blocking rule requires that by the end of 2022, all the vendors are required to implement a specific version of FHIR. So it requires FHIR and it points to a specific implementation guide. That's pushed out pretty far, for my taste, but as a part of, because of the pandemic and other things, over the last couple of years, that date got pushed out a couple of times, but that date is there, and a lot of vendors are moving forward with FHIR. But back to your question, though, I think that because more and more data is now available as structured and unstructured data, and we have cloud-based, cloud-based services, cloud-based ways of being able to, manage and analyze, large volumes of data from disparate sources. We're starting to see tremendous progress and growth of algorithm-based, approaches, and I think that we're going to start to see more of that as we start to, as the information blocking rule, for example, starts to require that electronic health information, which is to say more than just the structured data, but the entire record, quote unquote, is required to be made available starting on October 6th, 2022, which is not that far away. And so you start to say, well, the US CDI, which is now what's required to be made available in a continuity of care document or in your patient portal, for example, or via FHIR API, that's great, but it's 25, 26 data elements, whatever that is. After October 6th, the requirement is that all data be made available, structured or unstructured. And that lends itself, right? I mean, that invites, the application of algorithms to be able to make sense of all that structured and unstructured data. So I think that we're going to start to see an explosion of the use of algorithms to be able to, take advantage of that greater information that will be made available. And we should start to see more and more activity in that space. There are a wide variety of considerations that we need to have. I mean, from an equity perspective, there's algorithmic bias. And even outside of equity, there is algorithmic bias, as we know. There's recent discussion in the press about a particular EHR vendor that had an algorithm that was developed by some of the providers, I think, from 6 or 7 settings that had a certain amount of bias in it, not because it was intentional, but because it's only trained in a certain number of settings. And so you have the question of how applicable, how do we judge the applicability of particular algorithms that are trained in a particular environment to the broader ecosystem or in other settings. I think that's a sort of a question that that we're starting to engage in, and is certainly a big industry question for us. The last thing I'll say is that FHIR-based capabilities, though, offer the opportunity for us to have more scalability and replicability and substitutability of algorithms and other kinds of approaches of knowledge and of knowledge analytics. So, for example, how about a model, and Mayo Clinic is experimenting with this as well as other places, where within my system I can use the algorithms that were developed within my system. But why couldn't I have a FHIR-based CDS hooks, clinical decision support hooks, a software hook that enables me to bring in an expert algorithm that was developed at Mass General, let's say, and apply it to my data, or that was developed at Johns Hopkins, let's say, so that you can start to choose for which algorithms you want to be able to apply to your data. FHIR-based exchange and FHIR patterns of exchange enable that kind of capability.
Now, ONC does not regulate clinical devices, but some of the algorithms that are going to be circulating and available for installation are going to raise questions about quality and safety, or safety and efficacy. Do you think ONC has a role in that, in the assurance of that the public is protected from algorithms that don't work or that are more than biased but faulty? How do you see the balance between government and private action to assure the safety of consumers when it comes to the use of more and more sophisticated artificial intelligence?
Yeah, I think there are a couple of dimensions to that. One is that that ONC has sort of been interested and very focused on thinking about how should we think about safety in general with respect to health IT systems. A number of years ago, we actually had a proposal that went to the Congress and was not funded for the creation of a safety center or a couple of safety centers that would start to look at health IT safety in the way that the aviation industry, for example, looks at safety in a sort of a safer forum to be able to have lessons learned in a non-judgmental, non-shaming way that allows people to come forward and feel comfortable coming forward with safety issues that have been presented in their particular environments, and then be able to share those in a way that can help everyone get better. We're still focused on trying to figure out what's the right model to be able to have that kind of sort of approach, and hopefully we'll have more to share on on any progress that we can make there in the near future. But that said, I also would say ONC is we're kind of a service agency to other organizations. So we don't, have the authority necessarily to just go out and start to, make claims to be able to certify systems outside of a particular authority or outside of a particular sort of business use case. That said, what we're doing is, for example, we're working with some of our federal partners like the FDA, for example, and thinking about, how do we get better standardization of the data that they get? And whether it's from an EHR system or a device, how do we think about that problem of enabling the standards that that ONC has promulgated and made available for EHR systems? How do we think about that with other systems that are generating clinical data? And how do we think about leveraging those authorities so that we have greater consistency across programs? And let's say if the FDA wanted to think a little bit harder about how to put that into their programs, that's where ONC could play a role in saying, well, now we can sort of exercise the ability to have standards, the ability to have certain types of certification if it goes that far, into areas where we're not right now, because it's really got to come from the business owner that sort of drives the business requirement first. And then it's for ONC to come in and say, how can we provide you with the health IT enablement to be able to support the business goals that you're trying to accomplish?
So one of the safety aspects of the management of information and data whether through algorithms and AI or simply through exchange, is of course the protection of security and privacy of that data. We are dealing, of course, still with the HIPAA framework, which, as we are often reminded, preceded the internet. And at the same time, it's an incredibly difficult task even to contemplate how you would comprehensively rework our current privacy infrastructure. How serious do you think the threat to patient privacy is from this proliferation of third parties that are going to have access to patients' data if patients allow them to have it? This is an issue that we talked about a lot in the Karen Alliance, Micky, as you recall. Where do you think we stand with that now, and what is ONC's role in this privacy protection sphere?
Yeah, I just the short answer to your question is it's very serious. We're now living in a world where where the technology, at least in the U.S., not true in Europe, but in the U.S. or most of the U.S., California has a data protection law, which is different than the rest of the country. But in most of the U.S., the technology has outpaced the policy, which is to say, as you pointed out, we have information, medical record information, clinical information that is crossing the bounds of HIPAA protection in a way that the individuals who have that information now in their hands don't recognize, first off, which is the first problem. They don't recognize that information no longer has the HIPAA protections that they think it has, and they don't recognize that there may be ways that their information might be accessed, that if they're not very, very aware and diligent and conscious of what they're agreeing to when they start to click through those apps and the fine print on those apps, if they're not very conscious of those, they might have their data exposed in ways that they really didn't intend for it to be exposed, and that could have sort of long-lasting consequences for them. So I think it's a really serious problem. It's not new in the sense that going all the way back to you remember the blue button back in the early 2000s, which was about making data available to patients in ASCII files. And then we moved to the view, download, transmit through patient portals. And I remember there was a very vigorous and engaged Health IT Policy Committee discussion as we were coming to the approval of the requirements to have the view, download, transmit requirement available in patient portals. There was a very vigorous debate at the policy committee about this very issue, which is to say, how do we balance the desire and the obligation to make a patient's data available to them in applications of their choice so that they can make choices about what they want to be able to do that with that data. How do we balance that on the one hand with the fact that we are pushing that data outside of the bounds of HIPAA protections when we do that? And what's the relative balance there? And obviously, as a society, and I think we've sort of said, well, the balance has got to be on making the information available, because we can't in good conscience prevent the patient's right of access using modern internet tools to be able to have access to their information. And then what that means is we all have sort of an obligation to try to educate individuals as much as possible about about the risks that they're taking when they do that. So ONC has done a variety of things to try to help that. One is to make clear to all parties that education is a fundamental part of of everything that we're doing here. The second is that we have tried to do everything we can to make allowances to the extent that there was confusion in rules, for example, about our providers or vendors allowed to say anything to patients about the apps that they bring, because one subtlety for those who aren't deeply familiar with these rules is that that the requirement that was put into regulation is that a provider organization and or their technology vendor is not allowed to prevent a patient from getting information into the app of the patient's choice, as long as that app meets the technical requirements that have to be publicly available for connection to that medical record system. And so that was drawn with respect to patient empowerment, to say that we don't want providers, we don't want technology vendors standing in the way of a patient's being able to access that via whatever app they choose, and that's their choice. what we didn't want is to say, and this was where we provided a little bit of clarity, that what if a provider or providers and technology vendors feel a duty to be able to provide information to their patients if they think that they are, endangering the privacy and security of that information in ways that they may not appreciate. So, we did provide some clarity that says that a provider or a technology vendor, can provide information to a patient if they know that the patient is using an app that has these kinds of threats that have been demonstrated. There's more to come on that. We'll see. Secretary Becerra, obviously, being the Attorney General of California, has a deep familiarity and knowledge about these privacy issues, and so I think that as the administration has a little bit more time under our belt, hopefully we'll be able to raise that discussion to be something that we can work on in the near future.
But do you think it's fair to say that current law does not provide the authority that is needed to regulate the management of data and the privacy and security of data outside of the HIPAA provider framework, that is the covered entity framework?
Yeah, I am not a lawyer, and I'm not OCR, but my read, and I think ONC's a read on this, is that is correct. That the current law does not allow that. And so once you're outside, once you have downloaded that record into your app, the app that you control, then you're now the only, you have state laws that might provide some protection, and then you have FTC Section 5, which provides some protection about an app's accurately representing what it is they had in their publicly available privacy statement. But that's that's pretty weak protection, from my perspective.
Sure. I think we're at time, and I just want to thank you, Micky, for taking the time to be with us and express my appreciation for having you in the role that you're in right now. I think we're all very fortunate to have your leadership at the ONC at this point in time. So good luck to you, and we'll be checking in, I'm sure.
Great. Thanks so much, David. I enjoyed it.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about a Health Podyssey.
Health Podyssey is produced by Health Affairs, the leading journal for health policy research. The team behind the show includes Patty Sweet, Jeff Byers, Julia Vivolo, Sarah Kolk, and Sue Ducat. Like the show? Subscribe to a Health Podyssey on Apple Podcast, Spotify, Stitcher, Google, or wherever you listen to your favorite podcasts. Thanks for listening, and have a great morning, day, or evening.